So I just want to make sure I understood the question. So how do we provide palliative?
Approach that subject to people who are in need of that information but are in denial.
Mm-hmm.
Well, maybe I will answer that question.
Yes.
Hey, is that okay?
Come on up.
I think
Pat
that's
Richardson.
a very
Sounds
good
like a good question for Pat.
I think that's a very good question, and I think it's a societal question. Am I speaking too loudly? Whoops. Am I just right here now? Can you hear me? No. Not loud enough. Is that better? Okay. Very good question. You're talking about the term advanced care planning and palliative care and wondering how they fit together. Especially maybe in an environment where a person is fearful, doesn't want to talk about dying. And I think it's such a good question because it's a very common, I think, experience for a lot of people. And I think it's a societal issue. How do we as a society, as a culture, how do we in Vancouver address these issues? I mean, provincially, there are programs unrolling advanced care planning. People can pick up booklets called My Voice. I'm sorry, we don't have any here, but we can certainly make them available. If you leave your name and address, we can certainly send one to you. So there's a provincial program unfolding where people can write down their wishes. So I think it begins with a conversation and talking about it. Well, I think it's easy for all of us maybe here, I'm not sure about everybody in the room, but hopefully thinking that this is sort of somewhere in the vague future that we might have to think about our own mortality and death. But it's really something that we all should be thinking about and planning now for the future. I work in the community and in the hospital, and it is very common that people may approach me and say, you know, so-and-so in room 524, you know, they're really, really not doing well, but they don't want to talk about it. We don't want to talk about it. How are we going to approach the subject? And I think that when you're talking to somebody that you know well and that you love, it's understanding what their understanding is of their experience. So sometimes just the question is, what is your understanding of your illness? Where do you think you are in your lived experience? All of us have some idea. I mean, at the age of 62, I have a better idea than I did at 42 or 22. Most people have some sense of where they are in their lived experience. So it's asking people what their understanding is and then what concerns they have. And I think that's just a general question that people feel safe with. I think for us as healthcare providers, we always ask people, do they want information? How much information do people want? Sometimes people are afraid of talking about it because healthcare providers may give them way too much information, more information than they want, and it becomes a very fearful experience. I think sometimes what people are afraid of is even more frightening than what probably awaits them. Does that answer your question a little bit?
Well, how do you deal with those who are in denial?
Well, I'll pass it on to my colleagues. I guess personally, I think denial is sometimes a very good safety mechanism to make people feel comfortable. And I think each person experiences their own end-of-life experience in a different way, and it's to be respectful of how people accommodate their own mortality. But I'll let the experts talk about the evidence.
No, I think what Pat said was very true. All I was going to say is that although they may not talk about it with you, they may talk about it with their doctor, they may talk about it with their neighbor, they may talk about it with other people. So people tend to have little compartments or boxes that they put things in. You know, I mean, I even noticed that there's certain things I wouldn't discuss with my husband that I would discuss with my girlfriends, right? So this is often the way. So to kind of force someone into that conversation can be very challenging. However, even the most denying person, often if the doctor uses an approach saying, we're going to hope for the best, but let's take a few minutes to plan for the worst. Most people can understand that. And I often use the analogy, life is a bit like a car trip where you don't know, it's a long car trip, you're going to be going up and down hills, you don't know what you're going to experience.
The wheels might fall off.
The
from
wheels
time to
might
time.
fall off. You wouldn't go on a long car trip without taking some food with you, some clothes, some extra blankets, a change, you know, things like this. So why would you go on this illness journey without thinking ahead and packing some extra things. And, most people can kind of get that. And oftentimes speaking about it in a different way that's not where you're going to die now, what do you want? That doesn't work. So you have to look for very different creative ways.
And metaphors. And actually, I see some of the volunteers from Marion Hospice here, and I think that the volunteers have lots of experience in how people sometimes express where they are in their life through metaphors, through other ways of talking, that we may think people are in denial, but in my experience, when I visit people pretty much often have a good idea that things aren't going so well. Just yesterday, I visited somebody in the hospital, and he was still able to talk, and he was hoping for the best, hoping for recovery, but he kind of knew when I said, this is what you're hoping for, and what are you thinking will happen? Because what people are hoping for and what they feel will probably happen can be quite different. And I think that it's an element that's really important in palliative care is hope. I think all of us need hope to get out of bed in the morning or to open our eyes or to do anything. We need hope. And I think sometimes there's a perception that, you can't bring in palliative care because it will take away hope, because this means you're dying. And I think that that's something I'd really underline what the comment that Romaine made, that we see people very early on in a disease trajectory of an illness, or how the course will follow, and it's to help people improve quality of life and often actually live longer. But I think there's so much fear just around taking away hope. Sometimes I think the fear is more about taking away hope than it is about dying. I think most people know eventually we will all die, but the fear is that hope will be taken away. So I think that our volunteers explore that a lot. I know in Marion Hospice, I worked there for a period of time, and I think that, I don't know if you could comment on denial, but I think denial is just a way of people moderating where they are in their life. Did you have a particular situation that you could share with people about denial? Because I think it's an important episode.
Okay. So next question, and I must say I appreciate the good handwriting, because it's not like in the charts sometimes, but here we go. Should a representation agreement also be available to the medical team? And that's often very helpful for us to know, to have the representation agreement. And if you do have one, and you do happen to be in hospital, then we certainly recommend. Oh, okay. Yes, that's a good point. Representation agreement means basically, and I'm not a lawyer, but from what I understand, it means that you give somebody the instructions on what to do if you are unable to make the decisions for yourself, particularly with medical decisions. So often people will have a formal document describing exactly what they would want in certain situations, and often it's a more general document where they just authorize people to answer on their behalf. However, in BC, there's some specifics.
It's incredibly complicated, and the disappointment, I'm sorry,
No,
is that there's like a million different ways now to do it. A representation agreement is where you appoint a person to make decisions for you. One would hope that you would give them some conversation and a document, maybe, as Gil says, explaining what you think your values are and what kind of care you would prefer. But a representation agreement is just appointing a person. And, probably the best overall thing is appointing a person and giving some direction, but also trusting that person that they can best represent you, because it's very hard to predict what's going to happen. And so sometimes having a person who knows you well and knows what you would prefer in certain situations is the best solution.
Okay. So I'll try to answer them. With respect, so I'll repeat the question. And the first question was about whether or not the AIDS epidemic has had an influence on palliative care. Is that what?
Yeah.
And for sure it has. And definitely, before the new treatments were available for HIV and AIDS, people's life was often shorter and they often required palliative care. But I would say that just like any other illness, as somebody nears end of life, then they require good palliative care. And so I think it's had an influence because there was a lot of people that needed it at the time, and there was certain, like the Dr. Peter Center and other areas of specialization in BC for people with HIV that required palliative care. But I would think of it in general as any end-stage illness that needs good comfort care. Now, for the second, sorry?
And I think it helps shift the focus from palliative care being just dying, but
To live, for quality of life, right? Because, yeah. And then, sure. And then the second question is in terms of what draws us to the field of palliative care. I can speak for myself, and I think palliative care or palliative medicine is really an exciting area of medicine, and it's just an extension of other areas, but the kind of cases that we often see are patients with complex multi-system disease that require very complex workups and good diagnostics and evaluations, and they also require other elements of care like psychology and good patient-doctor communication and family-doctor communication. So for me, it's the wide variety of features of medicine that come into palliative care. That's what attracted me. And I just want to, okay, Dr. Gallagher, yes?
I just wanted to make a comment because I came to it through family medicine, and I think what I found is that my patients taught me, and I really found it very interesting work and an honor to be involved at such key points in people's life. It continues to be a wonderful job, and people do say, well, isn't it depressing? As my mom said when she was dying, she said to me, what does dying feel like? And because I still feel the same. And I thought, well, yeah, of course, you live until you die, right? And so dying is just as funny as living is. And I say funny, but it's also just as sad as life is. And really, the two are very much part of it. And it really, I find, gave me huge satisfaction because I'm not, I didn't necessarily go into medicine to cure people. I went into medicine to share the journey with people and to help them to make that a better journey, in other words. And I must also say that you never get through customs faster than being a palliative care doctor, and it also cuts off conversations at parties very well.
So the next question was actually from a previous note, and I'm not sure I can answer this one because it's more of a technical thing, but we'll try. Is it beneficial to state the palliative care award when you leave a donation for the St. Paul's Hospital Foundation? And actually, we are fortunate to have the new head of the Hospital Foundation here, so perhaps we should ask you directly. I think we are supposed to. You can designate a specific area in the hospital if you leave a gift, but I'm not sure if it goes to the overall.
And so this, again, is not an uncommon situation. This lady here is saying that her husband was very specific that he wanted CPR right up to the time of his death. And so do we provide CPR in the palliative care unit or in hospice? Is that? It was end of life, but in the hospital. Okay, so anytime we're treating people, our obligation is to provide the best treatment at the time when it's best able to help that person. What I find is that oftentimes people sort of have various myths about CPR and being resuscitated, that they actually think it's going to be quite successful. And they often worry that if they say no to CPR, that means no treatment. And so what I generally explain to people is that rather than saying, when your heart stops, do you want us to try and get it going again? I mean, well, who wouldn't, you know? But it's not the right explanation. The explanation is that we're going to do everything we can to help you live as well as you can for as long as you can, but at some point, you're going to die from this illness. And when you die, we won't try to restart your heart because A, it won't work. If you look at the chance of restarting a heart in a patient with, say, advanced cancer or advanced organ failure, there is a chance of about 5 people in 100 will get their heart restarted. They will then have to go to the intensive care unit and be on a ventilator and multiple tubes. And almost 40%, or 2 out of those 5 people, will have very significant brain damage. In addition, if they actually get their heart started and make it to the ICU, they're not going to be any better off than they were the minute before they died. In other words, CPR does not do a single thing for the disease you've already got, right? So I think oftentimes healthcare providers don't do a very good job of explaining what CPR is. And I'm in the midst of a study where we're making a video of what CPR is, because we actually think that people learn better when they hear things and see things, right? And because I've had people say to me, I want to be resuscitated. And then I began to talk about it, and they said, oh, but I don't want to be on machines. And I thought, uh-oh, there's something missing here. And when I actually described what CPR was, they said, well, I don't want that. I just want people to keep on treating me and make sure that, you know, a lot of people think that if they don't ask for resuscitation, that everybody will just stand back and watch them while they suffer. Well, that's not true, right? So usually I find that a explanation helps. The other fundamental thing is that we as healthcare providers need to offer you treatments that are reasonable medical treatments. You don't go into your doctor and say, I've got this infection, I've got a bladder infection, but I don't want Cipro. I want you to give me such and such. You wouldn't say, well, you know, I want this antibiotic, not that one. You're relying on us to sort of say, I think this is the best choice for you. So to some extent, the physician and the team needs to help people out by making them aware of what's available, but also what is most appropriate at a particular stage of illness. Does that make sense to people? Yes. Well, if you've got another few hours, we can help you. Well, Pat's going to get up for a little bit, but I also want to point out there's a great resource on the back of your sheets called Canadian Virtual Hospice. And it's a website, but it has all kinds of resources about body, mind, spirit, what you can do, what you can say, how you can be helpful. And so I'd highly recommend that site. But Pat, do you want to say a little bit?
I'll just say a few words, but it does come back to the question about what, sorry, speak up? Okay. Okay. Oh, just speak louder, okay. It comes back to the question about what draws people to palliative care. I think that a team approach is probably one of the core values of palliative care. I think that in order to treat body, mind, and soul of a patient or a client or a resident or a person, human being, and a family, it does take a team. Certainly for expert diagnosis, treatment, medical treatments, we need experts. We're getting more and more expert all the time. But we also need all the other members of the team. We need counselors, we need volunteers, we need social workers. What's going to work for my mind isn't going to work for your mind or your heart or someone else's soul. I think it's really understanding the individual and the family and the environment in which an individual lives, and finding out what the needs are of that person and family. Virtual hospice, it's true, is a tremendous resource for giving people ideas. Some people I know, Romaine was talking about, what's it called? We call it cupping. Treatments that, there are Eastern treatments that people use. I work at a very multicultural hospital where people come with Eastern values and beliefs about what's helpful to them. So it's really kind of understanding the personhood and their values, because that's probably what will help them most significantly. We can do all kinds of medical treatments to people, but if we're not doing it with people, it's not really a benefit to them. So I'm not sure if that answers some of your question. It's pretty vague, but you really have to go back to the person. Yes?
What about the clergy?
Absolutely. A body, mind, and soul. Some people have very deep spiritual values, and they may not have been participating in an active religion for a period of time and then rediscover something that was meaningful to them 30 years earlier. People express their spirituality in all different kinds of ways. And I think from a palliative approach that we try to support people to find their own spirituality, because I think actually most of us somewhere within us have one, even if we haven't remembered in recent years. Sometimes when we're going full circle in life, we come back to beliefs that were important to us earlier. Volunteers, I think we can all be approached from different perspectives. Social workers, counselors, psychologists. There's just so many avenues. As complicated as human beings are, there's all kinds of ways of supporting people.
I just wanted to point out a very practical thing that I find very helpful when people are visiting in hospices or palliative care units is remembering, reliving, reviewing life, right? The good and the bad. And that can be a very joyful thing for people to do. I mean, obviously, some people have had many, many sad times. But even though people may have had sad times or hard life, I have always been amazed at how people can find something good in the worst situations. And so to sometimes ask people, well, you know, tell me about what was important to you in your life, what was the most meaningful thing in your life, that kind of what we call life review can be extraordinarily helpful to people in kind of reviewing. And you also give them a sense of you're important to me, I want to know about you. And that's a really practical, helpful thing that we all can do to kind of share things back and forth, and it can be really lovely to see. Yeah, I mean, it is really interesting, and I think, again, some things are left up to the judgment of the healthcare provider. So for instance, if you might be in a hospital and you have a do not resuscitate order, if you were choking on food, we're not going to let you choke on food. So yeah, I mean, it's about using, what it acknowledges is that I'm going to die from my illness, and when I die from my illness, I want to spend my last hours and moments with my family around me, not having people jump on me and do things and put tubes down me. So yeah, and you're raising the sort of the a rare situation that we find doesn't happen very often. You know, the thing I have to mention is that in 1960, when they invented resuscitation, they did a very bizarre thing. And they sort of said, as soon as anybody steps into an acute care hospital, they should be resuscitated by default. You know, so that was nutty, and we can't reverse that now. We really should not be giving people treatments unless they might benefit from them, right? So really, we should be saying to every person who comes in the hospital, would they benefit from resuscitation? Well, if you've come in for a daycare surgery and you know, you're otherwise well, or you've got a chronic illness or two, but you're doing fine, of course we should resuscitate you. But, you know, if you're nearing the end of your life and you've got multiple significant illnesses which are having a huge impact on your ability to live your life, then no, we probably shouldn't, right? But the whole thing, you know, the camera's not on, the whole thing's kind of ass backwards. And we're kind of stuck with that, unfortunately. And I would think it would take a very bold organization to say, we are changing this around the way it should be. You know, because we don't sort of say, as soon as you get into acute care, you're going to get an x-ray of your chest. You know, so if that explains it.
Although that's
Although that very much happens, yeah. Well, on your ward, maybe on acute medicine, but we try and rationalize
And I
things.
just want to add a little bit because I actually started nursing when we were first starting to do resuscitation. And in those days, I think compressions were 3-to-1, and it was very exciting times, tiny bit over 40 years ago. And at the same time, I think palliative care was starting, and I think that's the interesting thing when we go back to the beginning of the slide presentation about where we are historically over hundreds and thousands of years, is at the same time we were developing incredible technologies to prolong life with all kinds of diseases, with cancer, with, developing wonder drugs, more and more potent antibiotics. At the same time we were developing all those, I think some people were feeling we're kind of losing track of where this person is in their lived experience, and I think that's what we're talking about. Resuscitation at the natural end of your life is really not a respectful thing to do. Resuscitation, when it's of benefit to somebody, is a very good thing to do, and we're getting better and better at knowing how to resuscitate. But when you're at the natural end of your life, even if you were resuscitated, even if it did work, you still wouldn't be as good as you were at the day before the natural end of your life. So I think that's really important for people to know about, because I think it's terrifying to get this piece of paper, black and white, saying do not resuscitate. People have told me they feel like they're signing a death warrant. I say you're signing an insurance policy that you're in control of things, especially when you're at home. When you have that piece of paper at home, you're the ones who know that it's there. If you phone 911, you don't have to present this black and white piece of paper that says do not resuscitate. But by law, what people don't know is if you phone 911, the paramedics are compelled by law to try to start resuscitation, whether it's a benefit or respectful or not. So that's why when people are in the hospital and they're being approached about a do not resuscitate form to take home, it's really to protect people. It's not a death warrant. So that's part of the explanation for no CPR. Thanks.
The doctor writes, do not resuscitate, do they check with the family members?
So the question is, if a do not resuscitate order is written, does the person writing that order check with the family first? Usually these discussions are best held, like most people sort of say, serious illness is a family experience, and I want my family to be around when we make these decisions. Other people will say, no, I don't want my family involved. I can make my own decisions, thank you. And this is what my wishes are, or this is what I would prefer. So it varies from person to person. If you're well enough to make decisions, and I know that sounds, what I want to say is we presume that most people are capable to make decisions. If people get really sick or they get serious dementia where they can no longer understand the implications of what they're deciding, if they become incapable of making that decision, then we go to the person who they may have nominated as their decision maker, or their temporary decision maker, which is decided according to how you're related to the person. So depending on the situation, is the person able to make their own decisions? If they are, I usually say to them, do you like to make decisions on your own or with your family? You know, how much information do you want? I've had lots of people who didn't want the full story. You know, they don't want chapter and verse, just the you know, the front cover and the list of the chapters, please, not all the details. We need to learn to respect different ways and different cultural ways of dealing with illness. You know, I just want to I realized I haven't answered your question. You talked about different levels of CPR. And I find people often get confused between what tends to be called levels of intervention and do not resuscitate. Have people ever heard of levels of intervention? Yeah. And it really, CPR, and I hope I can explain this properly, CPR only refers to if you should happen to drop dead, okay? Whereas there's a whole lot more decisions that need to be made, right? So supposing you've got, like our fellow Mr. C, you've got chronic lung disease, you might have to decide at some point whether you think you might prefer, if you got sick enough and going to ICU and having a breathing tube down your throat, if the doctors thought that might benefit you, would you want that? So that's decisions. You might decide whether you want to treat a pneumonia or not, or where you might hopefully like to die. You see, and those kind of decisions are levels of intervention, as opposed to what are you going to do for me if I suddenly drop dead? Does that make sense to people? If I suddenly drop dead, I mean, usually that's how people misunderstand CPR, because that's all it was really intended for, and it never was intended for natural death, right? But unfortunately, because they made this thing like, let's resuscitate everybody and see how it works, you know, that was about 50 years ago. Sorry, Pat, you weren't, no, Pat, it was 1960.
The first hospital they had
Okay.
for the cardiac.
Yeah, very good. But she really wasn't, she's not that old. You know, they thought they could save everybody, right? And so after a very short time, they figured out that this wasn't working very well. In fact, those rates that I was describing, like if we took, say, any of us here, we're all pretty healthy, but if we went up to the hospital wards and looked at the rate of getting a heart rate started again, it's more like 17 out of 100, okay? Because you'll have some people who are not too bad. They might just have a problem with the rhythm in their heart or something, so they might actually benefit from it. But as you get more advanced illness, the chances of success or restarting the heart becomes less and less and less and less. And, you know, so it never was intended for natural death. Unfortunately, that's the way we've got it now, and that's why we're so keen to get people to understand that this is really just when you die, we're not going to try and bring you back, is what I try and explain it.
But not resuscitation.
Yes, very good point. And the question is, what if you've got multiple illnesses and you don't want to be resuscitated, but you're very short of breath, or you're having chest pain? You know, you're sort of thinking, will they resuscitate me if they call them? If you have what's called a community DNR, this piece of paper, and you can Google community DNR or community CPR, And so many people might like to just have that on their fridge. And, usually people can even get bracelets that say no CPR. And I've even seen people with night shirts that say no DNR. Maybe your kids can get it for your Christmas present. Um, you know, but yeah, but a Pat, thank God you're here. A community DNR form needs to be signed by your family doctor, okay? Because it means that you've had that discussion, that the doctor thinks, yes, it's not likely to benefit you, and you don't want to spend your last weeks on a machine. If that's, many people think that and don't want that. So you need to discuss it with your doctor, but there is a form that you can have, and then the ambulance can come. So I've been there actually where I was at a place and I thought, you know what? I need the ambulance guys here. I need some of their drugs. But there's no way they were going to resuscitate this person. So I called them and they came, and it really helped the person, but they didn't resuscitate.
But they took them to a hospital?
Yes, they required some hospital treatment. Yes, but they, didn't do that. Oh, sorry, Helen. Where can you get those forms? Any doctor, like I would recommend that you talk to your doctor and have one, because the doctors could just download them and then review it with you and you could sign it. And so that's where you can get them. You can also get them on the internet. Well, because I was the attending physician. Well, in this case, they'd only be compelled to do resuscitation if the person actually died. Okay? So, you're not going to start doing things to people unless they die, i.e. their heart stops and their breathing stops. They'll always come. It's just that in the event that, and many people who are older sort of say, well, hell, if I have some event in the middle of the night and someone finds me dead in my bed, good for me. Do you know what I mean? Yeah. And so why would I want to, to stop that process, right? And so they'll actually have a community DNR, but they'll discuss it with their family doctor. Yes.
Okay, so supposing you're enduring power of attorney for something, okay, that would mean that you're very close, you've had a lot of discussion, everything. So when you go into the hospital and then there is a need for resuscitation, would it be to your advantage just to say to the doctor, I put you in charge, I'm sure you know what's best, because this person said, I don't want any tubes, I don't want anything?
Now, by enduring power of attorney, because I think,
Like with the representation?
yeah, with the so if, because many people say, I'm power of attorney. And I have to say, yes, I know you can pay their bills, but that doesn't mean you can make the medical decisions. And in BC, it's a bit crazy. We've got different rules for everything. You need a representation act, okay?
My question is, do you expect the person to question you and challenge you, or do you wish the person to say,
Oh,
I'm sure you know what's best?
you know what? This is where healthcare providers can really make a mess of it. If we don't explain to the healthcare representative, I usually explain to them saying, here's the medical situation. Your loved one or whoever you're deciding for is incapable of making decisions. Because, supposing you were my representative, right? If I could still make my own decisions, they wouldn't go to you. They'd say, well, she can make her own decisions, right? So it was only if I'm not capable. Then they would go to you and say, well, Romaine's got this and this and this. There's option A or option B, but I kind of recommend option A. What do you think she would say to that? So you see, oftentimes we make the mistake and make people feel terrible by saying, what do you want us to do? I think that's dreadful. We've studied for years. We should not be asking a family member or a friend, what do you want us to do? That's not really what the role you should feel you're playing. You should feel that you're saying, yeah, if I put myself in that person's shoes, I think they'd go for this. Or, no, I don't think that would feel right for them. Do you understand what I mean? So you're not many people sort of think, I pulled the plug on my dad, when in fact you didn't pull the plug on your dad. You felt that it was that your dad would have agreed with the recommendations of the healthcare team. Does that make sense to you? And oftentimes family members feel dreadful because they feel like they've been asked to make this decision and to, pull the plug. When in fact we're just saying, do you think they'd agree with us and consent to this? It's perfectly within your right to say, I feel comfortable with you as a healthcare team to make this decision. Because for all you know, that might have been exactly what that person would have said, is that I feel comfortable with this team making the decisions. There is nothing wrong with that. That is representing the values of the person that you were asked to represent. And it's certainly not pulling the plug. So I hope everybody heard that. The brief summary is that this was a person who had advanced illness and was being fed through a tube. They were informed by one staff saying, I don't think this is the right thing. In fact, I think it may be causing harm. Then when the family thought, we agree with this, and asked the team to stop the feeding, they felt like they were being accused of killing him. A, I'm glad this wasn't Vancouver. B, what year was this?
It was 2002.
Okay, that's sad. You know what? I would say that amongst even healthcare professionals, there is a lot of confusion over the difference between euthanasia and the withdrawal of treatment. And I have personally run across healthcare providers who feel like they're doing something bad when they're removing a feeding tube. And so that's when we involve our ethics team, because if we have a healthcare provider or somebody who's sort of thinking, I don't feel good about this, or I feel conflicted about this, we get the ethics people in to help us sort through this. I'm so sorry that happened to you. We tend not to even offer feeding tubes anymore in advanced illness because it doesn't stop people from choking and aspirating. People are typically not hungry near the end of life. And as you may all remember living here, that lady who took the wrong turn off, her and her husband, they got stuck in the desert, and she went 7 weeks with just water. I use this story all the time because I say, look how long you can survive without food. People don't starve to death. They die from the underlying illness, okay? And it's very common not to be hungry near the end of life. So sometimes feeding someone, especially forced feeding through a tube, can be very, very uncomfortable for people.
I guess the one thing I would add is, when you think of palliative care, don't get nervous. I'm looking around the room. I want people to be kind of reassured that if something should happen, then you know that the healthcare providers that are going to look after you will hopefully put quality of life at the forefront. Because it seems like you're coming here to find out a little about palliative care, and that's how we think about patients, is we first ask, what can we do to augment the patient's quality of life? And as Dr. Gallagher alluded to, sometimes if somebody has a pneumonia, improving their quality of life means treating it with antibiotics if it's treatable and if it's reversible. But for patients that, let's say, have an irreversible condition, then there's still lots of stuff to do to make sure that their quality of life is maximized and that their comfort is maximized. So that's how I would think of palliative care today.
That's amazing. see you guys are.
Yes, very good attention.
Good attention span. Thank you very much, and if you want to come up and talk to us personally after, we'd welcome that. Thank you.